Hi, I'm Warwick Nettle, plastic surgeon. I specialise in all things face, and I'm here talking today with Dr Russell Knudsen, Australia's foremost hair transplant surgeon, all about hairline lowering surgery and hair transplant surgery.
Hi, I'm Russell Knudsen. I specialise in hair restoration surgery and have done so for the last 30 years. It's my full-time practice, and I have worked with Warwick over many years on patients who we've shared hairline repairs and improvements, and so we're going to give you some detailed information today about the possibilities that hair restoration can provide to you.
So Russell, just as a general thought, hairline lowering versus hair grafting, what are the pros and cons, do you think, of each particular?
The hairline lowering technique that you utilise is a very good technique for getting instant results for people that have stable hair loss or congenital high hairlines, for example. So if you have a progressive hair loss, that technique is going to bite you because the hair will move away from the surgery and you'll be left with the same problem but with a scar. So if you've got stable hair loss or a congenital, something you're born with, you're unhappy with, it's great because you get instant density, instant result.
Yeah, and I guess that's why at least 90% of our patients are female. I imagine a lot of your patients are male.
Yes, 70% of my patient load is men with progressive male pattern balding, which is why that's not a technique that works for them. But certainly there are some men that have congenital high hairlines, and if we can demonstrate that really they're not moving, then that becomes a viable option.
How easy is it to demonstrate that their hairline is not moving, Russell? There are men who seem to have a really good hairline at the age of 30, let's say, and by the time they're 45, 50, it's really moving backwards.
Well, it's a risk the patient will have to take, because if you have a family history of no hair loss, then you can show me photographs from your teen years where your hairline looks to be exactly where it is now. You're still going to be warned about the possibility of further hair loss, but that's a risk-reward ratio the patient can tolerate, then they might accept it. But as I said, it's pretty unusual for men to do it.
And doing the actual hairline restoration yourself, do you actually put in each and every single follicle?
Okay, so hair on the scalp grows in a very specific manner. They're called follicular units for the scalp, which means that typically you will see between 1 and 4 hairs in a naturally occurring group, an anatomical group, what we call it. So basically the hairs are put in their individual groups, and then you just design where you want those groups to go. So for example, at a hairline, you're going to put single hairs in a random scatter zone to start with, and you can do that in front of any other surgical scar that might be there. And then you're going to put groups of 2s and groups of 3s and groups of 4s scattered in behind. But each one goes in individually, and the direction and angle is calculated to make sure that it flows in a natural direction, because there is a natural flow to hairlines.
Yeah, it's a really interesting thing. There is very much a natural flow to hairlines, and well, not just hairlines, but also the way the hair is oriented. And I suppose that is one good thing about hairline lowering, the surgery. It actually just picks up the natural hair, moves it forward and places it down. Tell me, has a lot changed? Has a lot changed in hair grafting surgery over the last 10 years or so?
I think the last 10 years in terms of the implantation techniques that we use is the least change we've had in the last 30 years. So the very, very big change occurred between 1985 and 1995. So people still talk about plug transplants or plug grafts as if they're still done here, but to my knowledge in Australia they haven't been done since 1995.
They were pretty special looking, weren't they?
Well, the problem was that it was based on a dermatologist's decision making of an operation. So in the US, which is where this style of operating developed, it came from a dermatologist. So he adopted a dermatological punch biopsy technique and adapted it to hair, and that's what.
So I guess that's the instrumentation they had available, wasn't it?
The 5mm punch
biopsy that you bonk like that and put it bang back in there.
So it was designed to be like a chessboard. You know, it was a 4-stage process. You did every white second white square every second black square, and then you came back and did the other white squares and came back and did the other black squares. And if you could get more than 80% of your chance to the patients to the fourth operation, it probably didn't look too bad with careful grooming.
Yeah.
The problem was that so many of them fell out along the way, and for dissatisfaction or for other reasons, that we left them with these weird looking results. Everybody thought, well, yeah, it grows, but it looks terrible.
Yeah.
And it was, I think the word is it was incomplete, rather, which is why it looked terrible, because it was incomplete. Whereas today, because we use the natural groupings right from the first operation, the only difference between the first and second operation is density, not naturalness.
How dense should hair be to look good? How many follicles per, say, square centimetre or whatever?
It's really not a number. It really is a percentage, I guess. And what I mean by that is that we have a surplus of hair on our head visually. So you can take...
You may talk for yourself, Russell, but some of us maybe not so much.
Technically, we have a surplus of hair on our head, so that we can take hair out of the scalp without anybody noticing. And so there is a certain percentage you can take out, which will vary from person to person because of the characteristics of the hair. For example, is it fine hair? Is it coarse hair? Is it curly hair? Is it straight hair? Is there a high colour contrast between the hair colour and the skin colour, which makes it easy to see through? So these factors are variables and influence it, but you can take a certain amount of hair out without it being noticed. So if you reverse that logic, you don't have to go back in with 100% density to get a good result. And that's just as well, because all hair transplantation techniques involve moving hair from position A to position B. We're not creating new hairs, we're not adding hairs to the head, we're redistributing it. So really the art is to get just enough hair from the back to the front to give you a visual result that you can live with. I call this a minimum comfort zone. And what I mean by that is that if the patient says, okay, you know what, that doesn't look too bad, I can live with that, then we stop. We don't put more in because we may want to use that later on in case there's further hair loss. Right? So the real answer is we aim for approximately 50% of normal density. And that usually gives you enough visual density to diminish the contrast between the thicker area and the thinner areas to an acceptable level.
That's fair. I'm not sure if any studies have been done on it, but with hairline lowering, what seems to occur, and Sheldon Kabaka, who we both know, says this as well, he's one of the gurus of hairline lowering surgery from the US, that there is actually a thickening and an increased density of hair follicles in the area that's brought forward. Now, whether there is actually an increase in the number of hair follicles, or whether you are simply removing some of the fine hair and really just bringing the thick hair forward so that it's like abutting the area of the forehead where there's no skin, is very hard to know. But he actually feels there is an actual increase in the number of hair follicles.
Yeah, it's kind of counterintuitive because you'd expect there to be a stretching effect, which means you'd expect the groups to be a little bit further apart. But there's also a stimulatory effect with these surgeries. And so, for example, people should understand that not every hair that's on your head is growing at the one time. Right? There's a constant cycling going through. And the average is somewhere between 85 and 89% of your hairs are growing at any one time. But there are things that you can do that might take it up to 90 something. So you can use medications which stimulate hairs to grow. Hormonal changes, for example, women who are pregnant have a massive amount of hair in the second half of the pregnancy because they stop shedding. And they stop shedding because their estrogen level is going up during the pregnancy. So they have this magnificent head of hair in the second half of the pregnancy. And the baby's born, and when they have the baby, they shed because the stimulatory effect is withdrawn and they go through a temporary molt.
Right. So they go back to where they were before they retain all the hair, hopefully.
But then what we do see is some women who come in and they say it didn't fully regrow, and that's when we discover that it's unmasked previously undiagnosed early thinning pattern.
Tell me, a lot of people are asking about platelet-rich plasma or platelet-rich fibrin and stem cells injected deep to the scalp. What are your thoughts on that?
Okay, so platelet-rich plasma has been around for a while now, and I'm not going to say it's controversial, I'm just going to say that its level of evidence has not been great. up until this stage. But I think you've got to put these things in context. The idea behind platelet-rich plasma is that the clotting cells, the platelets, have growth factors inside them, so that when you inject the serum, the plasma, with the platelets into the scalp, the platelets come in contact with the collagen in the skin, they crack open and release the growth factors. Now, the thing that people need to keep in mind about this is that the hair has to be stimulatable. And the best way to describe that again is to say that if your hair shaft, which has a certain thickness, gets to less than 50% of its natural diameter as it shrinks as part of some of these conditions, then it'll never come back to being a healthy hair. There's no one that's ever grown a hair from less than 50% of its diameter back to 100% of its diameter.
Okay.
So you really, all of these stimulatory treatments have to be done in the early stages of hair loss to have any chance to work, whether it's drug therapy, laser therapy, or PRP therapy. Now,
so you can't bring it back from the dead, basically.
You can bring it back from a fuzzy hair to a less fuzzy hair.
Yeah.
You can't bring it back to a healthy hair.
Right, so get in early.
Get in early. And so basically all of these treatments are better at prevention than they are at recovery. And so that's why early, and unfortunately people procrastinate about these things, and so often people tell me, oh gee, I wish I'd come in a couple of years ago, and I'm going, I wish you had too.
Yeah.
You would have got a better result.
We have that in facial surgery as well. People often leave it till they're huge jowls, huge big hanging necks, and if they've done something 5, even 10 years earlier, it's a much better operation, looks better, works better, lasts longer. So it's generally the way that if you can do things a little earlier rather than later, it's worthwhile.
That's right. So again, we're trying to, we have, basically hair therapy works in largely 2 fields. You have your blocking therapies, which are usually prescription medicines, and then you have your stimulation therapies, which may or may not be prescription medicines. And so it really depends upon the cause of the hair loss. So unfortunately the field is very confused because there's 1,000 products out there in the marketplace all making certain claims, and without wishing to be terribly derogatory about it, you've got to think about where you get these products from. In Australia, you can bring products in under 2 regulatory regimes, the cosmetic regime or the therapeutic regime. Guess which one's the tougher one? The therapeutic regime, because if you're going to make therapeutic claims, you have to prove them.
Yeah.
If you're going to make cosmetic claims, you don't.
Yeah.
So when you see things may or might or could and that has stimulant, that in it, they're not making a claim. And if you look carefully,
it's just a vague sort of like put it out there.
It's almost a promise.
Good luck,
but not quite. And of course, they don't put enough product in it to make it look like it's that has to be regulated.
Yeah.
And that's the catch-22, right?
Yeah.
You just, for example, caffeine shampoo. Okay, yes, you can prove in the laboratory that caffeine has a mild stimulatory effect on hair. Does that mean that they put enough in the product to actually make that clinically happen? No.
No, it's probably just written on the side of the bottle.
Well, no, I'm not saying it's not in there.
A tiny bit.
But there's only a little bit in there.
Yeah.
So Warwick, you've been doing hairline lowering surgery for a while now, and I think we said earlier in our
about 11 years now.
Okay, and it's almost always a woman.
Nice. Yeah. Probably at least 90% of our patients for hairline lowering surgery are women, and the main reason for that is that women want an instant result. They're not interested in transplanting follicles here, waiting several months for it to grow. And then the other thing as well is, on a negative way, males often have unstable hairlines, and with the instability of the hairline, if you make an incision along here, it may well be hidden early, but then as the hair recedes, the incision becomes more obvious. Now, the incisions are really terrific these days, and people like Sheldon Kabaka have shown us all how to make those incisions as good as humanly possible so that they're extremely difficult to see, but it's fair to say that no incision is ever invisible. They are difficult to find and difficult to see and well hidden, but they're never invisible.
Okay, now the other one, well, so that's like, you're talking about congenital high hairlines, people that are born with this high hairlines.
Yeah, women.
What about people that might have a burn or have a hair loss associated with radiation that's killed the hair follicles in the area, Can they be suitable for this technique?
Not for that really, Russell, for that particular technique, the hairline lowering technique, which is useful really for advancing the scalp forward. Generally, if there's radiation or a burn, it's certain areas which are affected. And certainly they are suitable for scalp expansion, so expanding the hair-bearing scalp.
We put the balloon in.
That's right, you put the
expand it
balloon in,
over.
you put the saline in over 4 to 6 weeks and blow that area up so it's really, really large. Then you take the balloon out and you move the area around. You move that area to, you create a flap and move it to a different area. So they're suitable for that, but not so much the more traditional hairline lowering technique.
Okay, yes, so we're talking about a specific technique that makes a smaller degree of movement, and you're not dealing with an active disease process. It's a single time operation, doesn't require multiple weeks of preparation. And,
that's right, yeah, it's a one-off. And the most suitable people for hairline lowering are females generally, because they have nice thick hair and it's generally a stable hairline. And particularly if they have a mobile scalp. And scalp mobility, as we all know, can be tested by essentially putting your hand just over your ears and then rocking the scalp backwards and forwards on the skull. Some people I've seen, and probably you've seen over the years, really can just practically go the whole way down, the whole way back. It's quite extraordinary. Right. It's almost like a circus trick. And others are just stuck solid. They just can hardly move anything at all. Those people who are stuck solid, it's very much harder to make the hairline come forward easily. And those people generally can get 1.5, maybe 2 centimetres of hairline advancement if they're lucky, whereas you can get 3 or 4 centimetres quite easily in people with good scalp mobility.
I bet you get asked whether you get a brow lift out of it as well with this procedure.
Yeah, and the answer to that is not if you don't want it, and yes if you do want it. So certainly one can elevate the brow at the same time as hairline lowering, but it's by no means essential. If you're happy with the position of your brows, leave them alone.
All right, so let's talk about shaping of the hairline when you're doing the hairline lowering technique, because you're creating an instant hairline. I think we should let our people know that the term hairline is probably not a very good term. It's a hair zone.
It's a transition zone.
That's right, and it's irregular. So the design, if it's going to look more natural, can't be too clinical, otherwise it draws your eye to it. So how do you get that rounded look, particularly when you're dealing with women?
That's a really interesting point, Russell, and a lot of thought and effort has gone into this over the years, because there's no doubt that the early hairline lowering procedures essentially advanced the frontal hair only, leaving temporal recession, and women don't like that. Women don't like to have that temporal area. Now, of course, one was always able to put hair transplants in there if possible, or if one wanted to, but generally people want a one-stage sort of operation and don't want to be fussing around doing other things if they don't need to. So now, whereas previously the incision would perhaps stopped here, I'm going right down here. So the flaps are getting very, very much broader, even by 3 or 4 centimetres easily each side, to move the entire hairline forward. Now, that doesn't help in the situation of gross temporal recession. Those patients simply need to either do hair transplants in that area of temporal recession, or move the hairline forward as much as they can, including that temporal area, and at a later date put some fine hair transplants in there. So we send them off to you to get those little areas fine-tuned.
The starting shape is going to determine what the operative technique is going to do.
And the other thing too, of course, as you alluded to, a very straight hairline looks unusual. A lot of people think when they come in they want hairline lowering surgery. How come it's not like straight, and you just lower it straight? If you do that and you can morph it on a computer, it looks really weird.
There's nothing on the face is straight. Everything is curved on the straight.
Totally.
On the face.
Totally.
So talk to me.
Almost nothing is ever completely 100% symmetric.
Correct. There's a lot more asymmetry in hairlines and faces than people think.
Do you know there's more people being born these days with asymmetry of the face? And the theory goes that when people of your and my age were younger, we used to sleep from side to side to side, and even on our face. And with SIDS coming along, parents are having the kids on their back, And so the pressure on the skull is essentially pushing forwards only. They're not getting that side-to-side slipping, and it's causing more and more facial asymmetry. So it's an interesting thing to deal with in future.
Fascinating question. One other thing that strikes me about this is whether there's any difference in your technique due to the natural hair angling at the hairline. So we have women and men with cowlicks where the hair is presenting either laterally or posteriorly rather than forward as it normally does. And how does that influence the process?
Yeah. So obviously it's really a discussion before the surgery and an assessment. A person who has posterior exiting hairs, like their hair, the cowlick type hairs, if it's that bad that it's going to show up in an extremely obvious way, then obviously you just wouldn't do that sort of surgery. Or else what you would do is move that area forward and, if possible, remove the cowlick if it's anterior enough, if it's forward enough. So you move the entire hairline forward as much as you can, remove the cowlick. Or you can move it forward, remove some of the cowlick, and even do transplants into those areas to make it look less like a cowlick. It's a very important point.
I haven't met too many women that like cowlicks because it really restricts their grooming options.
Yeah, it's just luck with the draw, isn't it? Just pure luck with the draw.
Can't win them all.
Yeah.
Does the surgery, affect the growing hairs post-operatively? Do they stick? Do they fall? Do they come back if they fall? What happens?
So hairline lowering is a permanent operation. It permanently moves a large number of, thousands of hair follicles forward onto the forehead. Those follicles stay there essentially permanently. Now, with any operation, you can get temporary hair loss. So if you have a big toenail that's an ingrown toenail and you have a general anaesthetic for that, you can get temporary thinning of the hair.
We're talking about hairline lowering, post-operatively numbing where the surgery is done at the hairline. How long would that last?
Yeah, so the biggest issue in terms of sensation with hairline lowering is that the scalp is completely numb, like 100% numb at first. The numbness all wears off. It usually takes somewhere between 6 to 12 months. It's variable in people. But a really important thing is hot hair dryers. A lot of people use hot hair dryers to dry their hair after a shower. If you are using a very hot hair dryer, you can actually burn yourself. Or else if you take scalding hot showers, you get it onto your scalp and you've got that numbness
and
straight
no
up the
sensation.
hairline, no sensation, you can burn your scalp. So we always warn people about that. But the sensation always does return and returns to essentially normal. In terms of washing and showering, people can shower the day after surgery. I'm not sure about you, Russell, with hair transplants, but it's been known for more than 50 years that wounds heal better wet than dry.
Yes.
So we always say to all of our patients, rhinoplasties, facelifts, eyelid surgery, get it wet. There's absolutely no problems getting it wet. Now, there's certain dressings we don't want to get wet.
Yeah.
However, wounds themselves, get them wet.
Yeah, no, we use wet healing technology as well.
Right. So after a hair transplant, what sort of time for showering?
The next morning, but we're also using sprays immediately post-operatively. So we spray salt water, saline, with a liposomal energy boost in it that is designed to feed the energy the cells can use while the individual grafts are trying to grab blood supply from the surrounding blood that hasn't really reconnected to the graft yet. So it's in that diffusion passive phase. You're trying to give a little bit of energy to it to see if we can get those hairs a bit healthier and not to suffer the consequences of not being connected to the blood supply for a little while. So yes, wet healing technology is very important. So I agree.
You've never had anyone who's had a shower the next day, turned it on full bore, it's gone whoosh like this, the whole lot flies off?
There's only 3 circumstances I've ever seen graft dislodged after my type of surgery, the individual grafting. One is knocking your head on the car door when you leave the clinic, there's Murphy's Law. Knocking your head on the cupboard door when you get home.
Murphy's Law number 2.
Murphy's Law number 2. And the third one was the patient unwisely applied an ice pack right to the graft and left it on long enough for the graft to freeze to the ice pack, and when he pulled the ice pack off, he dislodged the graft. But luckily he only lived around the corner, he was able to come back, we were able to reinsert the graft. But really, you know, the grafts that I do stick in very well within 48 hours.
Sure.
So you'd have to give it a pretty good whack in the first 24 hours to dislodge it. And you know, I let patients gently comb their hair, not just wash it, but gently comb it the next morning, as long as the tines of the comb aren't scraping across the scalp.
Yeah.
So, you know, and people say, well, of course, I've got to be very careful when I sleep on the pillow tonight, or otherwise it's going to dislodge. Never, ever has that happened on a pillow in 35 years.
Yeah.
Never.
It is interesting. A lot of people think that the surgeries that we do, both hair transplant and also hairline lowering, or even any other facial surgery, is extremely delicate. I mean, I guess the surgery itself is delicate, but it's quite robust, it's quite strong, and you really need to go out of your way to try to damage it more than anything. It's amazing how strong and robust it all is, and able to withstand a lot of daily usage. With hair transplantation, how long for exercise? Like, you know, I guess there's a greater response, and, you know, say walking, I suppose, is pretty much straight away, but how long for things like weightlifting or you know, yoga or Pilates, where one is straining?
Or do you want the truth, or do you want me to tell you what I tell the patients?
The truth, Russell. Definitely the truth.
The truth. The reality is, I think that most normal levels of exercise could be safely resumed within 7 days.
Mm-hmm.
But I like to tell my gym junkies, which is a significant percentage of my male load, because I've got 70% of my patients are men, and they don't have an off button. So I like to say 14, knowing that if I'm lucky to get 10, I might get 7.
Yep.
So I'll say 14 to them, because if I say 7 to them, they'll be back into it after 3.
Yes.
So, you know, the reality is you can be guided a bit by discomfort too. So, for example, the grafts aren't going to shift after a week here under any circumstances. So it more or less depends upon how we took the hair from the back, and whether stitches are involved, and whether there was a significant degree of stretching and tightness on the back of the scalp, whether that would cause enough discomfort if you put strain on. But certainly for things like cycling, walking, mild exertional aerobic exercise, no problem. Weights, a little bit longer.
Yeah, so very, very similar with us. Things that are weights or straining. You know, when you lift weights up and the veins pop out on your head, you know, that's the sort of manoeuvre, it's called the Valsalva manoeuvre, as you know, that we really prefer people not to do, you know, in a common sense manner for at least a couple of weeks.
Well, the thing is that you can get post-operative swelling, obviously, with the operations, and in the type of hair transplantation I do, it's delayed, meaning that ordinarily it is in the 48 to 72 hour mark after the surgery, which is usually moderated somewhat by icing and the other things that we apply, cortisone injections during the surgery. But, you know, it's going to last 2 or 3 days, and then gravity can drop it down the head, and that gives them the black eye in that circumstance, which they're not happy with. So that's, you know, but you can get that done within a week. So as long as you're not doing any exertional thing in the first week, you're not going to aggravate the situation.
It's amazing how quickly some people do get back to work and normal routines. I guess after hair transplant surgery, but certainly after hairline lowering, we have people that I might call day 3 post-surgery, and they're, yes, quick, you know, I'm in a meeting, and I'm like, you know, who are you in a meeting with? And they're in, you know, really quite important meetings, and they've had hairline surgery 3 or 4 days earlier. It's extraordinary.
And also the level of post-operative discomfort is so incredibly variable. So, for example, I would estimate that 50% of my patients don't use any post-operative analgesia at all. I can't pick them, by the way. I can't pick which one is going to and which one isn't. But that seems to be the report that I get back, is that only half of them bothered to take anything.
I think that's true in almost all facial surgery. People come in saying, you know, say with rhinoplasty, gosh, it's going to hurt, isn't it? And at least 90% of people say they have no pain at all, like at least 90%. Now, I wish it was 100%, of course it's not, but at least 90% of people say no pain. And, you know, hair transplantation surgery, clearly very, very similar. Hairline lowering surgery, not much pain generally.
I think that 10% rule is about right, because in fact it's probably the number of people that swell is less than 10%. So I think there's just individual healing differences for people. I think there are mechanical forces that cause discomfort more than anything else. And I think there's a bit of individual variability, but a good positive metal attitude doesn't go astray.
Doesn't go astray. Helmets. say for motorcycles?
A week.
Yeah, a week. Really?
No
Okay,
problem with
because I'm a little bit more conservative. I tell people, you know, generally motorcycle helmets around about 2 weeks, 3 weeks, because what I don't want them doing is like yanking it up off of the head and disrupting the things that are being moved. It's robust, but there are limits.
You've done scalp movement and scalp stretching, right?
Yes.
You've reduced the flexibility of the upper scalp by haven't,
Yes.
right? There's no reduction in flexibility here.
Yeah.
In the surgery, if there's any reduction in flexibility, it's in the neck, which of course is still covered by a helmet. But if they're comfortable to wear the helmet and comfortable to have the head in the position that they can use the helmet, and then they're not putting excessive stretch on the neck, and I'm comfortable with that, because it's not going to have any impact upon the grafting.
Sure.
Sunburn does. Sunburn does.
Sunburn.
Okay, so my one big bugbear, and remember, I'm mostly dealing with men with the balding, so they don't have much hair in the area to begin with, and we're putting grafts in to help increase the coverage. But there was one report in the medical literature of a patient who unfortunately got a severe case of sunburn within 2 weeks or 10 days of having a surgery and got extremely poor growth. Now, we don't know that that is necessarily directly a cause and effect, but it's enough to make us be very, very wary that we don't want to have a major inflammatory episode in the scalp from UV sunburn. So I do tell my patients to keep it covered, and also until the hairs are growing, to get a lot of sun block on the area.
Makes sense.
Because with my type of surgery, 50% of the hairs will grow straight away, typically. 50% of the hairs will temporarily shed, which is just a disconnection from the blood supply, having to find a new blood supply problem. It takes 3 months for them to start to recover, which is the 4th month. So by the 6th or 7th month, maybe 2/3 to 3/4 of the hairs are growing, you're getting good coverage, you've got less risk of sunburn, but that first 6 months is still risky.
Takes a while. Eyebrows. Can you put hair transplants into eyebrows?
Yes.
Does it work? Does it look good?
Now, unfortunately, we can't usually use eyebrow hairs to do eyebrow transplants.
So where do you get the hairs from?
Scalp, typically.
Oh, okay.
Okay, because typically 95% of the eyebrow transplants we do are on women who, unfortunately, in a fit of fashion sense,
plucked.
So this was a youthful indiscretion, if you like, and they excessively plucked their hairs, and then they decided that having plucked it, they're now sparse and they want it back. Well, there's nothing to transfer in there from the other eyebrow, for example. So we use scalp hairs, and the good news is they grow. The bad news is they grow, because they grow and grow. So
you need to snip them, otherwise you're going to have like a
so you have
cascading.
You have angling. Yes, that's Snoop Dogg. They grow. Scalp hair grows at 1 centimetre a month for 3 or 4 or 5 years.
Okay.
Eyebrow hairs grows at a much smaller rate for 3 months and stops. So you're not dealing with a similar pattern of hair growth, which means that you have to warn the patient that they will need to continue to trim and train the hairs, because they have to sit very, very flat on the scalp. Obviously the design is that there's a kind of a sweep of different shapes across the eyebrow that we do, and we can boost existing hairs, but it's not a set and forget. If you're going to do an eyebrow transplant, and as I said, it's 95% is for this excessive plucking, you have to commit to the idea.
Lifelong maintenance.
Lifelong maintenance, and it may slow down a little bit over time, but not that much. And also you also want to try and find hairs on the scalp that are a sympathetic fit to the calibre of the hairs in the eyebrow, because they tend to be coarser.
So there's an artistry to it, obviously.
Now, eyelashes, I know that some people ask about that as well, and the short answer is that most eyelash surgery is done for reconstructive purposes, not for cosmetic purposes. And the reason is because as long as you've got something wispy there, we have medications now that actually do stimulate eyelashes probably enough to give them a cosmetic result without doing surgery. So I really think that I don't personally regard eyelash surgery as cosmetic so much as restorative surgery, and that's very tricky, because again you've got to make sure that the angle of the
angle
hair
would have to
is,
be absolutely
and
perfect.
the curvature has to be away from the eyeballs so that you
that's-
don't get any ulceration on the eyeballs. So
Yeah.
very tricky surgery,
Tricky.
not performed very much around the world. It's the least easy thing to do.
Tell me, what's the weirdest surgery you've ever been asked to do in terms of hair transplantation? What's the strangest request you've had?
Yeah, the strangest request I had was only about a year ago from a patient who had been to another surgeon and had this done, and he felt that he had a bit more hair on his legs than he liked and a bit less hair on his arms than he liked. He wanted to transfer them, from the leg to the arm. Now, the reality is you can take a hair from anywhere in the body and transplant it anywhere else, one by one. All it has to do is get a blood supply and it will grow. And in fact, we've had experiments where scalp hairs have been planted into the leg and grown like scalp hairs on the leg, and then retransplanted back from the leg into the scalp and grown quite happily.
Wow.
So that can be moved around multiple times if
Oh.
you did it carefully enough.
So did you do it?
Yeah. I wasn't sure the logic of it, but
And the
Yeah.
patient happiness level?
I don't think so.
Okay.
I don't think he was a very happy patient.
Yeah, or maybe some issues with body dysmorphia
I
there.
may not have made a good decision on the proceeding.
Yeah, maybe. The weirdest thing I've ever been asked to do was make someone look older. And it was a fellow around about the age of 35, 40, and he came in and said, look, is there any way you can make me look like I'm 60? And I'm like, what on earth would you want to look like you're 60 for? And he had some sort of strange reason, but clearly not a very stable personality. So I declined that.
I have declined a weird request, I suppose. I'll hesitate to mention it. But about 20 years ago, I had a 42-year-old patient come in who was in the early stages of balding, and I was very unhappy about it. And he understood that there was a link between male sex hormone and balding, so he asked me to castrate him as a therapy,
Wow.
which I respectfully declined.
Yes. It would work though, wouldn't it?
To a degree, yeah, it's true. In fact, that's how
because the old eunuchs.
that's how balding was discovered in
the harems used to.
Well, that's how the
waves of
link.
hair.
That's how the link was first discovered. There was the first paper on it was produced in 1942, and what had happened is that they developed synthetic testosterone. So we had a group of these patients that had either been castrated in industrial accidents or had other reasons, and they gave them synthetic testosterone. And within weeks, some of them started to lose hair. So the funny thing about that is that if it's going to happen in weeks, there's obviously an age effect as well. So I think there is an age sensitivity of hairs towards hormones, which is why balding is progressive in life and why it tends to get worse as you get older. So if you're injecting hormones into a young man, it might take a long while before you get too much hair loss. If you inject hormones into an older man, it may not take very long at all.
With some patients, they do request an extremely low hairline, and I'm sure you come across that as well. With hairline lowering surgery, we do get the occasional person who really wants 2 or 3 centimetres above the brow. As we know, around about 5 centimetres is usually a very good distance.
For a woman, and men's usually a bit higher. It's about a centimetre or a 15 mil higher for a man. But yes, we do get those requests, and the thing that people need to think about is harmony and balance. Yep. And so in men,
one third.
Yeah, well, in fact, what I find in men is that and some women is the middle third is the smaller third. So it's not really a third. So I really try to match the lower third to the upper third, because sometimes the central face, the middle face, is a bit compressed. And I think that when you actually do it, I think they get it, because as much as they would like to have as much hair as possible, and the other thing to remember in my men is that they usually got progressive hair loss. So the lower I come, the more I'm committing to the front, the less I can commit later on to the back.
Yeah.
So it's a trade-off for them if they go too low at the hairline. So it's better that I try and keep it conservative at the front and keep something in the donor bank for later on, because let's face it, despite all the hype that's going on at the moment, we do not have stem cell transplants. We do not have cloning yet as a viable treatment option. The problem we've had up until now is the experiments in the animal studies have been more successful than they have been when we take them to the human studies. And one of the reasons for that, we think, is that the human hair is an incredibly complex organ, much more complex than we thought it is. It was only in 2010 that we discovered that every single hormone that a human makes can, in theory, be made by the stem cells in the hair. They are that pluripotential, meaning they have that
Fascinating.
plasticity.
The question on everyone's lips, stem cells and cloning of hair follicles. How far away are we from that?
Yeah, the same answer I would have given 25 years ago.
That far?
5 to 10.
Oh,
it's
always 5 to 10 years away.
5 to 10 years away. So here's the issue.
It's like the cure for cancer.
Okay, we know that the hair organ, because it is an organ, the stem cells are incredibly flexible, which is another word for plastic, and they can do anything. They can make any hormone in the body, for example, which we only discovered recently. But the problem is that as the hair ages and as the balding or other things continue, the stem cell population declines. Now, the hairs don't actually so much die, it's just become incredibly inactive. So the promise of the future is to use the healthier lower scalp hairs that are genetically coded differently and expand the stem cell lines and then inject them into the upper scalp. Now, the two strategies I think they would like to have tried, number one was, let's see if we can put a bunch of stem cells together, inject it into the scalp and see if we can grow a hair. Now, it's been moderately successful in animal studies, but pretty unsuccessful in human studies for two reasons. One is you can't culture the cells for longer than about 2 weeks before they start to degrade their genetic information.
Yep.
So that makes it difficult. Number two, you can't control the direction, so you end up with a fur ball.
Right.
So you get these abnormal looking hairs that are growing in abnormal directions.
Might
So that-
become a trend.
Yeah, maybe. But it's not really not been a successful approach. Another one that's being trialled now, which I think potentially has more promise, is to supplement the existing stem cells by injecting them in, hoping they migrate to the existing cells, and not to try and create new hair, but to create a temporarily boosted hair.
Mm-hmm.
And if you can do that, if we can get the stem cells, and without getting too technical, the big improvement in the technology in the last 5 years has been to use 3-dimensional cultures instead of 2-dimensional cultures, because that seems to preserve the genetic coding better. So is it around the corner? No. Do people inappropriately talk about it and advertise it and talk about hair cell multiplication and talk about stem cell transplants? Yes. No such thing exists. It doesn't mean it can't exist. It just doesn't yet exist.
What do you say to those people who swear that they've gone to Thailand, they've had platelet-rich plasma, placed underneath their scalp hair follicles, or under their scalp, and they claim to have more hair? Do you think it's a real thing, or do you think
there
it's
is
a placebo?
I think there's a mild stimulatory effect potential in some patients with using platelet-rich plasma. We certainly know it stimulates collagen and elastin production in facial skin, which is the things that the so-called vampire facelift that people do. And some people think it works better in different regions, obviously, than others. I don't think hair has been particularly successful, partly because we've been doing it in a more active condition rather than a passive condition. So if you're doing an active balding, which is a very specifically hormone and related condition, I'm not sure that any stimulation therapy is terribly effective for terribly long. The rule of thumb is if you're using stimulation therapies, maybe 40% of your patients are going to get a temporary boost. The problem I have is I don't know which 40%. I can kind of guess, because they have to be in the early stages of hair loss, which we talked about earlier, rather than the later stages of hair loss. But I'm dealing with an active condition. If you're talking about aging hair loss, because as we age, everybody's hair numbers go down a little bit, and their hair shaft diameters go down a little bit. Interestingly, for women, it's different to women and men. So for men, the number and the shaft diameter decreases from the mid-20s. In women, the numbers start to decrease in the mid-20s slowly, but the shaft diameter increases until the early 40s, which we think is an estrogen stimulation effect. And then in the 40s, when their estrogen starts to decline as they come towards menopause, they start to lose shaft diameter as well as numbers, and that's when the peak time for them to come in and start to worry about thinning. And that's an aging effect, not another effect. So again, early preventative treatment is good, but we don't have any cure for these things. So, you know, if you're going to commit to the idea of treating it, you've got to commit to the idea of treating it indefinitely.
Mm.
Let's get back to talking about your, you know, shaping of hairline. When you're consulting with the patient says, I want the hairline lower.
Yeah.
Where does the conversation go about the shape and the design?
So there's several rules of thumb. Most females basically don't like the hairline to be more than a centimetre above the area where the skull goes from being vertical into that transition zone into horizontal. So if you have the hair, basically it almost doesn't matter that much how vertically long the scalp is or the skull is, but if you have the hair more than a centimetre behind that transition as it starts to round off, most females don't like it because it's a very masculinizing effect. It makes them look sort of like a lot older, a lot more male, and even alien sometimes. It's just a very, very undesirable sort of effect. So with the conversation essentially goes to, well, look, it's often not good to go directly to that transition point, to the very lowest part of that transition point. It often looks good to be just ever so slightly above that transition point, because it looks a bit odd having a vertical skull and then hair. It always looks a bit better having just that tiny, tiny little bit of roundness, but
like
not too much.
Looks like someone's put a wig on it.
Yeah,
so
yeah, it does look very wig-like. It's a very good way of looking at it.
So the point that I think you're making is, of course, is that skull shape is going to...
skull shape's incredibly important.
Is going to have a big influence on how that should actually work.
And then, of course, being slightly wavy rather than a straight line. And what we get people to do is several things. Firstly, I morph on the computer the potential sort of hairline that I think looks good. And more importantly, though, we get people in the sort of like, you know, comfort of their own home to get out an eyebrow pencil and draw on themselves exactly where they would like the hairline to be.
Yes.
And that's really useful for several reasons. It gets people to really think about what they're really wanting. And I also get them obviously to send that to me, and we get people who clearly just want the temporal area done, and I say to them, you know what, hair transplant's a better idea than hair lowering surgery for temporal areas. We also get people who are wanting, you know, 6, 7, 8 centimetres of advancement, being incredibly low, and it's just totally inappropriate. Firstly, it's very, very hard to get 6 or 7 centimetres of advancement, and secondly, it looks awful. And it's always surprised me with some people how they can tolerate a really, really abnormal and unusual look just for the sake of it being better than what they had. So for instance, in rhinoplasty, a lot of people have the complaint that their columella hangs quite low. And if you do a morph of those people and you obliterate their columella, which looks incredibly abnormal, like if you saw someone who had that, you'd think, wow, that's a very weird looking nose, but they actually like it. And I think it's almost a little bit like anorexics. There is a little bit of dysmorphia that is associated with some of these conditions.
Something's got to be better than this.
Yeah, something's got to be better than this. Therefore, you know, if a little bit is better, a whole lot is a lot better, and that's not necessarily so. So shape and distance of the hairline incredibly important. So we get people to draw on themselves beforehand, send that photograph to me. If I think it looks good, like aesthetically, and I've got a fairly finely attuned aesthetic judgment, then absolutely no problem. But if they're going into an area that's starting to look weird or not quite right, then we just say, hang on, let's have a think about this. Let's talk further about this.
I do the same thing. If I draw a potential hairline on a patient, I often get them to take a selfie in the consultation and go home and have a think about it, because we know that sometimes, you know, when we're changing things dramatically, it's kind of confronting to the patient at the start to see whether they really feel that they're, you know, going to be challenged by that much of a change, but over time they come to adopt it. And the other thing I think is that patients, once they've got a chance to think about it, show it if they're prepared to show it, although for a lot of my patients it's secret men's business, they aren't going to tell anybody. But they can become more comfortable with it, and then I find they come back in and they're more reasonable in their requests, right? They're not asking for something quite so much once they've had a chance to think about it. So I think there's a big advantage there to them taking the selfie in the first place.
I'm not sure if we can hear that siren in the background, but emergency hair transplant surgery.
Better go back and get it done now.
Better go back to the office. Russell, it's been an absolute pleasure talking with you.
Warwick, it's been a pleasure to talk to you as well, and I hope we have many more years of working together quite successfully.
Good on you, Russell.
Cheers.